Hey, it's Dr. Centeno. Thanks so much for joining us this morning. I got an interesting topic, as usual. Today we're going to talk about DMX at Centeno-Schultz Clinic. What's different? What's the same? We have over the last 6-7 months, we made the decision to bring DMX or video fluoroscopy, digital motion X-ray, whatever you want to call it, into our clinic. A lot of that had to do with a convenience factor, meaning we have a lot of patients that travel and they would have to have one place to go at the clinic and then have another place to go to get a DMX if they needed a DMX. So we wanted to try to streamline all of that. So that's the topic for this morning. After that topic, you can get into any question you want, whether it's about DMX, CSC, DMX at CSC, or anything else. Just go ahead and put your questions in the comments. I would suggest that you get your questions in there early because in general, what happens is by the end of the hour, I usually have more questions than I can answer. So try to get those in as early as you possibly can, and that means that I'll be able to get to them. For those of you that are just joining us now, we're going to be talking about DMX at Centeno-Schultz Clinic. What's different? What's the same? And then getting into, as usual, extensive Q&A. So if you've got questions, again, put them in the comments now, no matter where you are, whether you're on Facebook or YouTube. Throw those in the comments just because I tend to get more questions than I can answer in a 1-hour period. So if you don't get them in early, I won't be able to get to them by the time I've got to go. So let's start getting into this topic today. Digital motion X-ray or video fluoroscopy, DMX, digital motion X-ray, whatever you want to call it, is a pretty essential component of a craniocervical instability diagnosis. Now, there are other ways you can get there too. You can try cervical flexion extension, upright MRI. You can try just flexion extension X-rays. But this is one of the movement-based imaging concepts that's really key in looking for instability in the upper cervical spine. And as such, for years, we've worked with Dr. Katz's office in Boulder. Dr. Katz is a leader in this field. He's published an immense amount of research on DMX, what's normal, what's abnormal, and I really owe a big debt of gratitude to Dr. Katz for doing that. We've worked together for years. Having said that, it was always a bit of a problem for patients that came into the clinic, right? Almost all of our CCI patients are from out of state. And as a result, they then had two things they had to do, or at least some of them. Some of them would have to go to the clinic and they'd get a hotel obviously near the clinic, but then they'd have to go from the clinic into Boulder, which is about 12, 13-mile drive, navigate to where the DMX was located, get the DMX done there, and then continue to be seen in the clinic, etc. So we wanted to try to bring this all into one spot at the clinic. So let's get into this, DMX at CSC here. So what is DMX, or also called video fluoroscopy? It's live X-ray analysis of the neck. And we're looking at bone movement, looking for instability. Now, what is instability? Instability is movement beyond what's normal. And doesn't necessarily mean that that's causing symptoms, but it's helpful in trying to determine if we're looking at things that are moving too much, and then we can try to connect that excessive movement with whether or not that's causing this particular patient's symptoms. So the world of CCI, what can DMX or video fluoroscopy find? It's really good for looking at type 2B. In fact, I think it's the only way to get to a type 2B instability, and that's where C1, C2 has too much side-to-side movement. That's the alar and accessory ligaments. Now, also realize that that's a surrogate for C1, C2 rotational movement as well. It can look for a type 2A. I think it's the most sensitive way to find a type 2A. And that's where the transverse ligament is failing and you have too much opening between the atlas and the dens, or what we call the ADI, atlas dens interval, or atlantodental interval, you could also say. And it's also probably the most sensitive way to find types 3A and types 3B. That's forward and backward movement of C2 on C3. Now realize for type 2A and types 3A and 3B, you could also use flexion extension radiographs if they're done with maximum flexion and maximum extension, but you won't be able to see on a lateral, a type 2B, but you can also, and we work with patients on this all the time, do an open mouth lateral bending and see type 2B, again, on traditional radiographs, as long as it's set up correctly. Upright MRI can sometimes find 2A and sometimes find 3A and 3B, but it's not as sensitive. So if we were going to bring DMX in-house, my goal was to try to say, what are the problems of the current DMX landscape, right? What do I see as a consumer, as a physician consumer of DMX for all of these years? I've been looking at DMXs for 20 plus years. Well, there were problems in measurement that had to be fixed. There were problems with, I felt, reports that had to be simplified. We could also work on reducing the radiation dose to the patient. And obviously, we were trying to solve some simple logistics issues, i.e., if you get a hotel near the clinic, better to only deal with the clinic than having to go into another town to get one thing, and then you get different things at the clinic. So let's look at a very simple concept, and that is DMX distance measurement. Now, for most DMX machines, this really depends on how you set up the distances from the X-ray source to the patient, and then the image intensifier. The problem is that if you do that incorrectly, or if the patient moves forward or backward, or if the machine moves forward or backward relative to the patient, you get incorrect measurement values because there's this magnification effect. And so what you think is 1 millimeter isn't really 1 millimeter on the film or the video you're measuring. Now, a better way to do these measurements is to use a radiographic ruler in the field, which is what we're doing at CSC. So I'll show you what that looks like. So this is an example that I would come up against, I want to say maybe 1 in 5 times when I got a DMX report. I knew that the distance across here, across the dens, was about 10 millimeters, give or take. I think the smallest I've seen it is about 9 millimeters. The biggest I've seen it is about 12 millimeters. So if I knew that, then, and I had, let's say, an overhang that was half of that distance, I could say that that overhang measurement should be reported about 5 millimeters, give or take, 4 to 6, let's say. But if it was read out at 3 or 8, I knew that the DMX distances could be wrong. And so I will not frequently, but again, about 1 in 5 times, overrule the measurements I'm seeing in the report because they don't make sense with the anatomy. Now that's a big problem, right? When I get a report, I expect those distances to be spot on, but they weren't always spot on. So in order to fix that, we started looking at using a radiographic ruler, which you can see, it's that ghost-like ruler image that you can see there on the bottom of that AP view. And what this allows me to do is it now doesn't make a difference at all where the patient is located, where the machine is located. Is this patient leaning too far forward? Are they leaning too far back? Doesn't make a difference at all because I can set up my software on my end to measure a centimeter on the film. And then my software would be able to say, well, this number of pixels on the image equals a centimeter. So now I don't have any of those problems. So that's the way we're going to do this calibration so that we don't have issues with a machine that's too far away or too close, or a patient that's too far away or too close, causing measurement errors. Now, I've been a big critic, you probably heard me say this lots of times, of DMX reports, right? My least favorite DMX report on earth is what I call the damage report. This report drives me crazy as a physician. You get this yellow highlighted gunk, and you see these measurements, and it's saying damage, 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 damage. Now, the problem is, while some of this could represent damage, and some of these reports try to then redefine damage as an abnormality, sometimes this isn't damage at all. So for instance, there's a lot of findings in the lower neck that just represent wear and tear and normal aging. It's not really what we would consider damage. In addition, we've got other types of measurements here that may not be related to damage, which really tells me that there's some sort of traumatic, horrible event at all. They might be related to other things. So least favorite report on earth. I talk about this one all the time. I have talked more patients off the ledge after reading one of these crazy damage reports than I can count, because they get these reports, they freak out, as they should. And these reports, for the most part, are not transferring useful information that's actionable to the patient and myself. And then we get into overly complex reports. These don't drive me as crazy as the damage reports, but these can be very daunting to look at for a patient, right? You've got all these numbers, all these different values. Here we're measuring on the top left there, or off on the left, we're measuring segmental movement. That's being measured both angular or angular there. In other parts of reports like this, it's measuring translation. Sometimes it's measuring rotation. Sometimes it's measuring obscure measurements like a Powers ratio or Chamberlain's line, etc. Again, with all of this stuff, there's maybe a few numbers in here that are important for me to make a diagnosis. The rest of it is fluff, right? The rest of it is not actionable, and it's overly confusing to patients. So here's what I did is, I've gotten pretty good at vibe coding. So I vibe coded my own report generator. And I did it in such a way as to keep the focus on the patient, right? It talks about some stuff up in here that's maybe a little bit more technical, but down here, just like in the blood reports that you get from the lab, right? It allows you to see exactly where you are. This is normal over here. This is kind of abnormal, and this is really abnormal. So it allows you to really see where you live on this spectrum here. And that's a lot like the kind of blood reports you get. Same thing over here. So this one's abnormal, this one's normal. It allows you to quickly see what normal is, what value abnormal is, how close you are to normal, how close you are to abnormal, how far into the world of abnormal you are. Because that's a common question I get all the time from patients. How abnormal is this? Is it like a little bit abnormal? Is it a lot abnormal? Is this the most abnormal thing you've ever seen, etc. So this allows me to convey to the patient very simply in a way that they're used to seeing on their blood reports how far abnormal or normal they are, or how close to that abnormal line they are. Now, radiation exposure is also another question I get a lot about DMX. Well, how much radiation exposure is this? Now, sometimes these questions are nonsensical for me as a doctor, right? Patients already had a rotational CT scan and a CTV or CTA to look for IJV issues. So they've already had a lot more radiation exposure than you could ever get in a DMX. But other times, I think these questions are very valid, right? Are we really getting the most information out of a DMX for the radiation exposure that we are using? And the answer really is, honestly, that can be improved. So how can we reduce radiation exposure from a DMX? Well, really, the way to do that is to focus on parts of the imaging that provide actionable data for me as the doctor, and to get rid of parts of the imaging that aren't resulting in actionable information for the patient. So these are common DMX imaging. This is a common DMX imaging routine here. You can see here that it's usually flexion extension lateral views, then they go to flexion extension oblique views, then they go to AP cervical lateral bending, which is just like this with the mouth closed. Then they'll go to AP cervical rotation, and then finally they'll do the AP open mouth lateral bending. Now, of these, there's only 2 of these I really look at on a day-to-day basis that are going to provide me actionable information for that patient. So why not just focus on those 2? That would dramatically reduce the radiation exposure. So that's what we've done at CSC. So we've gotten rid of the ones in the middle here that aren't providing actionable information to me as the doctor, and we're just focusing on the ones that do provide actionable information for me as the doctor. And as a result, obviously, that's less fluoro time. Less fluoro time equals less radiation exposure. Hence, getting rid of DMX imaging sequences reduces radiation exposure. And then finally, logistics. This is a simple one. I started this out with this one. Before CSC, DMX patients needed to pay for additional lodging time because they usually had to stay an extra day or more. And then transportation to get to and from the DMX site. And that can be really stressful for somebody, especially if you've got someone that's from another country, right? They're disoriented because they're here in the US. The next thing you know, they have to catch an Uber or get a driver or rent a car to go into a different town, navigate that town, find another site, check in at that site, et cetera, et cetera. So obviously now that we have this at CSC, that gets rid of that logistical issue. So in summary, DMX or video fluoroscopy at CSC, we're focusing on simplified reports, lower radiation doses, simplified logistics, better measurement, I feel, as well. Okay, I think that's it for that topic. Let me get rid of that. And we will go to some questions here. E. Smith, when ligaments are injured, there's normally pain and swelling. Would injury of a previously injured ligament that never fully healed cause normal pain and swelling response? Would it be blunted? Yeah, it's a good question. Good way to answer this is that you get one bite at the healing apple, right? So you injure a ligament, your body tries to heal it. You get really one try at that. And if it doesn't fully heal, then it kind of goes into chronic mode where your body's trying to heal it, but it can't. So you get some chronic inflammation in the site. And if you injure it again legitimately, then you would get a second bite at that healing apple, but it might be a little bit more blunted than the first. And that's the whole idea behind regenerative medicine injections, everything from prolotherapy to PRP to bone marrow concentrate stem cells, is that you're trying to get a second bite at that healing apple that's as good at or better than the first bite you had at it. Crocavian, I have a telemedicine appointment scheduled with you soon. What will we talk about and how can I prepare? Also, I'm bad at English. Yeah, so what we'll talk about. So we're going to go over the questionnaire that you fill out. It's, I think, a 14-page questionnaire. We'll go over your imaging. I will have done all of that even before I get on with you because there'll be a pre-screen report issued. Your job after getting the pre-screen report is to do some research on the procedure itself and do some research on the diagnosis I made off the image. Now, it's not a full diagnosis because I don't have any other information, which to make a diagnosis, I've not done an interview, I've not done a hands-on exam. So it's just basically saying, this is what I think you probably have based on your imaging, and do some homework on that. Then when we get to the telemedicine, you're going to be directed to another website to watch a little video that answers common questions about the procedures. Then from there, we're going to start the telemedicine. I'm going to ask you some questions that I have about your 14-page questionnaire and your history. We'll go over some of the imaging, and then I'll tell you what I think you have Again, still can't get to a concrete diagnosis because I don't have a hands-on exam, but I can say at that point, yeah, I think you're a good candidate for this procedure, in this case, EPICL, or not. I think you should try something else than this. As far as English is concerned, you may want to go and have a friend help you. That's very, very common, where we have friends on the telemedicine who are better at English. If you have CCI symptoms but don't have CCI, what could be wrong? What or which diseases could cause such symptoms? Well, so if we're talking about upper cervical symptoms, it's either CCI, craniocervical instability, or CCS, craniocervical syndrome. Craniocervical syndrome means that you have injured structures in your upper neck causing symptoms but no instability. CCI is the same thing with instability. What other things could cause CCI-like symptoms? There would be dozens of things. So CCI or CCS would be diagnoses rendered, if appropriate, to try to tie together what's causing many times seemingly disparate symptoms. Sunflower, sorry, this isn't really DMX, all good. For patients who have very bad inflammatory recovery after CCI prolotherapy, how does the pain and paraflutter typically compare with EPICL? Yeah, if you had a very hard, rough recovery from prolotherapy, you're probably going to get put into the less is more centrally sensitized category. So that would mean that we'd be doing, let's say, a half of a full EPICL procedure to see how you respond, and then make some decisions from there. Usually we can open the throttle up on that as we go forward in procedures. If we use that approach, it's probably going to be pretty similar or less than a prolotherapy. If we don't use that approach, it'll be considerably more, hence the reason for using that less is more approach. In HEDS patients that develop CCI, is it that they always had lax upper neck ligaments and they go on to become more loose and cause symptoms? Yeah, I mean, realize that we all have lots of things wrong with our bodies, right? By the time you reach in your 20s, 30s, 40s, 50s, you get cumulative wear and tear in lots of different areas. Now, most of that, as you're younger, tends to heal and the symptoms kind of go away. Having said that, if it's instability related, then the cumulative wear and tear, the cumulative extra wear and tear due to instability, at some point passes that symptom threshold where you start to get symptoms. And that's generally what we see with HEDS or hypermobile patients. They tend to be hypermobile in lots of different places. And then over time, as they get older, they start to develop symptoms from that additional excessive motion causing wear and tear or cumulative wear and tear. Unstar, thank you for this. Can you offer input about limitations, C4 3.2, specifically C3 through C5 subluxations and flexions and winning screening for your clinic? I don't know what the question is, Unstar, there. Sounds like you have some mid-cervical instability. For my schedule, it would be, are you an EPICL candidate? Now, for the clinic general schedule, they could certainly help you with that mid-cervical instability, but I'm not quite sure of the question there. Vero, hello, Dr. C. When you inject ligaments with contrast conformation, are you able to see how damaged the ligaments are? How many PRP injections are typically needed for AC joint ligament damage? We are generally able to see the structure of the ligament. So yes, and then how many PRP injections are typically needed for AC joint issues? A lot really depends on how bad the ligament damage is and how far that AC joint is separated. So those are the things that kind of determine that. Unstar, in regard to imaging, my instability was found with upright MRI with flexion extension. Should I try to locate a DMX unit for imaging? Does your clinic do these? Yeah, so generally getting a DMX on top of an upright MRI is a good idea. And we do these. That's sort of the topic of today's thing. So yes, we do. Spin Advance by Harry Winston. I'm almost there. Been saving to get to for a long time. Well, great, Harry. Looking forward to see you. Caleb, can isolated suboccipital muscle atrophy cause CCI in an EDS patient? Maybe they have congenital laxity of the alar ligaments that become more loose from getting overloaded due to the atrophy. Yeah, Caleb, I think that's a really good and interesting thought, right? There's two components to stability, ligaments and muscles. And if you don't really have the ligament side because you're hypermobile or it's not working all that well, then you're really reliant on the muscular stability. And if the muscular stability goes south for some reason, then you're really going to be in trouble, right? Because you don't have the ligament stability to fall back on, and you don't have the muscular stability to fall back on. So that's a really good insight. Mark, I have instability at my cervical thoracic junction, and it's suddenly causing my entire body to turn bright red. It starts with my ears itching and then burning, turning red, then the neck, then chest, and eventually to my legs. What caused this? What can be done just to stabilize the joint? Mark, those usually aren't symptoms of cervical thoracic instability. So I'm not quite sure what to tell you there. Those aren't usually the kind of things we see with that problem. JS, do I ask my doc for an upright MRI, or is there such a thing as a motion MRI if there is not a DMX around me? Motion MRIs exist for research purposes, but they're not really generally available. You can ask your doctor for an upright MRI with flexion and extension for sure. You just need to find a place local to you where you can get one done. Hey guys, let's take a minute here and do a like, share, subscribe. Again, if you want to pay it forward in the CCI community, you really want other CCI patients to find this unique opportunity, right? I don't know of many physicians that give up an hour on their Sundays to be with patients and to ask questions. But most patients with CCI who think they might have CCI, who may not know they have CCI, don't really know that this happens every Sunday. So give me a like, share, subscribe so that the algorithm can figure it out and get this information to them. Vera, what would be the purpose of hydrodissecting the superior cervical plexus? When is this deemed necessary? What exactly is hydrodissecting a nerve? Yeah, so the superior cervical plexus lives underneath the sternocleidomastoid. It's contributed to by spinal nerves in the upper cervical to mid-cervical spine. It can cause radiating stuff that goes here, radiating stuff that goes here, and headache that goes back there. And it's usually hydrodissected because it's getting beat up because of tightness in the sternocleidomastoid muscles. And that tightness in the sternocleidomastoid muscles then causes issues in the underlying nerves. Hydrodissection means injecting platelet growth factors to try to help the nerves, also to break up any scar tissue there. So that's precisely done under ultrasound guidance to make sure that we're getting right around those nerves. Finnegan, how do you go about diagnosing CCI? Fully extending the neck, let alone moving an inch in any direction, causes extreme symptoms for the patient. You may not be able to do movement-based imaging, Finnegan. Now, obviously, now that we have DMX in the clinic, if need be, we could even do IV sedation with the patient. But normally, you can do oral sedation. So you can take some oral Valium to relax the muscles. You can take some oral painkillers to relax the muscles. But you're going to need movement to get CCI diagnosed. Awesome. What are your thoughts on hormesis, the theory that low-dose radiation like DMX is actually net positive for your health? Probably don't agree with that. I think the research that we have currently probably doesn't support that. You know, we've got two major schools of thought for radiation exposure, right? You've got one school of thought that says any additional radiation exposure is really bad. You've got another school of thought that says exposing someone periodically to medical radiation is really not moving the needle a lot. So for example, for something like a DMX study or a CT scan, single CT scan, you'd be taking maybe 3 or 4 days off someone's lifespan. But if someone is not active, you're taking up to 10 years, 5 to 10 years off their lifespan. So if you can get a diagnosis by taking off a couple days from their lifespan and then cause them to be active again, you're adding many, many years of health by doing that. But as far as radiation exposure at these levels being just a net positive, I don't think we've got much information that supports that at this point. Kelly, I have a PICL schedule the end of February. The current carotid Doppler indicates a possible 56% blocked left carotid artery. It was recommended that I get a head and neck MRA. Is it safe to continue the PICL as scheduled, or do I need to postpone? I also have hypotension with diastolic pressure in the 40s when lying down. During the PICL, how do you monitor blood pressure and ensure adequate cerebral blood perfusion? Well, Kelly, as far as the 50 to 60% blocked carotid artery, I think the next step is probably going to be seeing the doctors about that, right? If you're seeing a doctor about that and they say, well, Kelly, this is just par for the course. We just monitor this. We don't think there's any additional risk of this, but maybe it's concerning for your age. I can't tell your age here. So come back next year. We'll look at it again. Let us know if you have any symptoms, etc. So in the absence of any symptoms, and if that's just the diagnosis, and your local doctors and experts in that area have said, we're just going to watch this, this is not something we think is incredibly concerning right now, then there is no issue with the PICL procedure. We measure blood pressure. The procedure is done under anesthesia, so we're measuring blood pressure, heart rate, oxygen perfusion constantly during the procedure. Alex, as I've been stating by some people at 3 months, we feel looser, not saying there's more instability, but it feels looser. This has been reported by some people. My question is, why do we feel this at this time? Alex, feeling looser again is part of that donut hole video series. So I'd recommend that you watch that. But basically, what tends to happen in most people, not all, is that you'll get, let's say, 2 to 3 weeks of swelling within the ligament. Now, for most people, that feels pretty good during that time because they may be sore, but they're less unstable or a little bit more stable during that time period. Then that kind of goes away and people sort of go into the donut hole. And then over time, the ligament strength builds. Now, for most normal, healthy people, that ligament strength building is going to be at around the 3-month time frame. That's why we look at 3 months. But not everybody. You may well be in that category where it takes you 5 months or 6 months. But you may want to watch the video I did maybe a couple of weeks ago about not panicking, because again, what I see is patients panicking. And that's one of the good things about social media, is that you can find other patients who will say, well, God, I felt that, but at 4 months I felt great. But realize that you're already off the beaten path there into a minority of patients and not a majority of patients. And it's probably just wait longer, but watch that video. Alex, holding my alignment over 3 weeks now, longest ever at 3 months post-procedure. Yeah, so Alex, again, what that tells me is you're not more unstable, right? It tells me that you're more stable. Now, you may have additional range of motion, so things feel looser, or maybe you're more active, so things feel looser. But again, don't panic. Just go ahead and watch some of those videos. Stephen, patients with CCI, how effective is posterior PRP from Regenix clinics such as the one in Vegas, for example? Yeah, Stephen, a lot of that's going to depend on the type of CCI, right? So the first thing you need to do is to get the appropriate movement-based imaging to get it typed. 1A, 1C, 2A, 2B, 3A, 3B. For example, if it's a type 3A, then that could be a very good plan. If it's a type 2B, then that's kind of probably wasting your money because you're not going to get the kind of stability you need, because that's not going to get the orthobiologic, in this case PRP, where you need it. And there is no Regenix clinic in the country that is certified by Regenix to do upper cervical injections 0, 1, and 1, 2, which frequently need to be done in this patient population. E. Smith, feeling of pulling tangled cords in the neck when flared up. Is it muscles shutting off? Yeah, E. Smith, I think I answered that on the Reddit sub, but if you're saying pulling cords, that could be either irritation of the dura, which is the covering of the spinal cord, and nerve roots. It could be due to scoliosis, side bending. It could be due to a forward head posture. All of those types of things are the kind of things I would think about with that description. Vera, what could be expected after a PRP lumbar foraminal epidural injection? So whether it's PRP or platelet lysate after a platelet-based transforaminal low back epidural, most patients would start to feel better kind of in the 1 to 3 week time frame. That's usually what happens there. Her Royal Highness, sorry about that. At what C1, C2 overhang do you stop recommending a PICL where between 2 and 3 millimeters? So those numbers are totally off, but we don't even call overhang as being abnormal until we get to 3 millimeters. And then it's significantly abnormal when we get to 4, and we treat patients and routinely treat patients with EPICL in the 7 to 8 range. KCN, if the recovery from PRP happens over months, at what point can the person resume high intensity activities they haven't done for years but want to get back to? Yeah, KCN, that's an individualized decision for that patient based on that person's clinical history and my experience as a doctor with that person. So I really can't answer that one without knowing a lot more. Casey, is there a way to tell that PRP or BMC procedure is finished with all the repair? Yeah, so let's just talk about BMC since that's what's used in EPICL procedure. If you look at how long that would take based on our experience in monitoring ligaments that are easy to see on MRI, like ACLs, I would say that younger patients have full recovery in that MRI signal at around 3 to 4 months. Older patients can take longer, more like the 4 to 6 month range. And then every once in a while, you'll see someone that takes a lot longer in that 6 to 9 month range. But most people are going to be somewhere in that 4 to 6 month range. And if you're younger, it's going to happen quicker than if you're older. Not 100% accurate, but that's most people, right? You can certainly see a very healthy older person who's very active get a faster result than a younger person who's a couch potato, for example. What if you're allergic, or what if your patient is allergic to the contrast for the DMX? No contrast is used for a DMX, so I'm not quite sure what you're talking about there. So no contrast is utilized for DMX at all. No contrast should be utilized for even an upright MRI reflection extension. The only thing where contrast is used on the diagnostic imaging side that I see sometimes, and I think they're mostly not that valuable, is if you're getting a CT angiogram, CTA, or CT venogram, CTV. But a DMX does not use any contrast. Does a ligament injury cause a feeling of itchy-like, but not itch? Dull strain causing fatigue, internal tremor is not noticeable to the inside of the body of damaged ligaments. That wouldn't be a common description for ligament healing, no. Stephen, common for patients with CCI or CCS to have a white aura, like tunnel vision. I get it every day. I'm diagnosed with CCI from you. Can you touch on tunnel vision or aura and vision? Very scary. Yeah, Stephen, so there could be two things that can cause that. In a small number of CCI patients, they can get sort of not really blackout, but brownout type results. Every once in a while, you'll see them get blackouts as well. So it could be that mechanism. Could also be that the upper cervical spine can dramatically impact vision, including pupillary constriction and dilation, which could also cause a similar like thing. So you and I would have to talk about that to try to see on hands-on clinical exam if there's any explanation, but also would want to make sure that ophthalmology has taken a look at you to ensure that there's nothing that is being missed from that end. And obviously you've had a brain MRI to make sure nothing's being missed from that end as well. James is going to go over everyone's head here, but I will try to see if I can bring it down into the realm where everyone can understand it. So the question is, what specific peer-reviewed longitudinal data exists that definitely maps the exact proteomic signaling pathways through which autologous mesenchymal stem cells induce? Then I think the second part of the question is permanent structural regeneration in human ligamentous tissue, as opposed to namely running a temporary paracrine-mediated analgesic effect. James, I think so let's first try to break down what James is saying. I think he's using a bunch of fancy words, but may not understand what they mean. So let's go into what he's talking about. So in our body, we have mRNA, messenger RNA. And when that messenger RNA is expressed, you can get proteins that are made. And the good news is that rather than actually measuring the proteins in a specific spot, at least experimentally, you can look at protein expression, meaning that which RNA is being activated to make which proteins. You can call that proteomic or proteomics. You can also, using ELISA, measure those specific proteins as well. And ELISA, multiplex ELISA has gotten fairly sophisticated, where you can measure different proteins at different moments, and really dozens at a time. If you've got enough time and money, you can get it done. Now, that would seem to be really cool thing to do, and it can be because you can see that when different proteins are expressed, you might get different things to happen or different types of repair. The downside of that is that if you look the other way, the air conditioning kicks on, or you go to the bathroom, the protein expression and the mRNA changes, and or the proteomics can change wildly. So basically, proteomic data is interesting, but as humans, I have to be honest with you, this is one of those areas where AI will probably help quite a bit, right? We're probably not smart enough to understand what's happening with all those proteins, because if you're looking at 50 or 100 or 200 different proteins at once, you may be able to tell some big picture things about what's going on, but you're missing a lot of the fine detail because we can't keep, as humans, 100 or 200 data points in our head at the same time, like either today's very narrow AI models can, or in the future, more wide AI models. So as far as trying to look at proteomics or protein expression and then link that back to repair, it would make much more sense to just look to see if the ligament's repaired, which we've got published data on, rather than trying to do it this way. So again, lots of fancy words, but not meaning a bunch when it comes to practical science. E. Smith, will some have CCI with fully normal imaging due to muscle guarding or even a type of CCI that you have not defined yet? Sure, yeah. I mean, there's no doubt that we are still scratching the surface of what we can get out of imaging, right? In fact, I was just talking about AI models. I think that over the next 10 years, we will see the ability to have AI models, for instance, look at DMXs and look at the movement patterns and define CCI through those types of things. Right now, we're defining CCI by things that humans can easily understand, right? Does this part move too much against that part during this movement? But there's probably more subtle patterns there that we're not picking up that probably do represent instability. And hopefully over the next 5 or 10 years, that area, that kind of medicine will blossom. Another example is, all the gut bacteria, right? There's thousands of different types of bacteria in someone's gut. What's good, what's bad? We can define some simple things right now, but future AI models will be able to say that pattern over there is better than this pattern over here. And I looked at 200 bacteria at once to come up with that answer. Humans aren't capable of doing that right now. AI will be. Stephen, with CCI, is the instability causing movement that presses on brainstem, or how is brainstem involved? With certain types of CCI, Stephen, instability can cause movements that press on the brainstem. So common ones there might be, for example, a type 1A, low clivoaxial angle with a retroflex dens and a pannus. And you can see an indent in the brainstem. So now you can say, I've got high suspicion that this person, at least some of their symptoms are coming from that brainstem. Other types of CCI, for instance, type 2B, probably less reliant, that's side to side at C1, C2 or excessive rotation, on brainstem irritation, and more reliant on joint irritation and nerve irritation around that 1-2. So it all links back to the kinds of CCI. Vera, what is a typical total nucleated cell count range for BMC that you see among your patients? Thank you for answering these questions. Thank you, Vera. So for most patients, total nucleated cell counts are in the 400 to 1.2 billion range. If we had to create a bell curve for everyone walking through the door, for example, for a PICL procedure, we would see that peaks probably around 800 billion, and it falls off on either side to the 400 million side to the 1.2 billion side, and then tails off. We definitely see numbers smaller than 400 million or larger than 1.2 billion. But that's kind of how it goes. So realize, like everything in medicine or biology, we're all part of that bell curve. Most of us are in the middle of that bell curve. Some of us are on either ends. Brooke, does the patient wear a brace during PICL? I'm worried my neck will be moved, stretched while I'm asleep, stretching those ligaments even more. It's possible. We've done that a few times when we've had someone who is really, really, really hard to position. Now realize that is going to limit the amount that we can do, and so you'll get put into that less is more category. That's not the worst thing in the world, but it would mean that we could only do the things that we can accomplish with your head straight, which would be most of the PICL from the front, and then the midline ligaments and let's say 1-2 facet joints from the back. We wouldn't be able to do other things that we normally do because many times that requires small turns of the head to accomplish that. Unstart, what can be offered for multi-level CCI, but the MRI states the upper cervical CC junction is stable. So then that's not CCI, right? CCI means craniocervical instability. You may just be talking about cervical instability, which would be instability elsewhere. And so that really depends on, is the instability in flexion or extension? If the instability is in flexion, then generally posterior ligament injections would be the way to go. Prolo PRP, bone marrow concentrate. If the instability is in extension, then you would need anterior treatments of that anterior longitudinal ligament, same types of injectates. Cassian, how do you distinguish if a pain is referred or the original site? Do you know referral patterns and go backwards to find what may be symptom silent source of referred pain? Yeah, so for example, Cassian, pretty much every structure we deal with has a referral pattern. But for example, on hands-on exam, so let's go over a simple one, right? C1, C2 facet. That's the joint that helps you rotate your head 50% at C1, C2. So 50% of all your rotation comes from there. Now I can go and palpate, meaning press on that C1, C2 facet joint, and it can cause pain. If it causes pain, then I know locally it's painful. And then the referral pattern for C1, C2 facet is kind of like right across here, kind of like if someone took their hand and went like that, and it kind of spreads out horizontally. So that's a good example of both I can palpate the joint and determine that the joint itself is painful, and the referral pattern. Now, is it possible that the referral pattern is there and the joint itself isn't all that painful on palpation? That is possible. So we can work backwards from that referral pattern and treat that joint as well. JS, if you have cervical stenosis and myelopathy, do I treat the instability first, or is instability repair resolve the stenosis? I would need to know more about that, but if what you're talking about is that in the mid to lower neck, you've got a tight spinal canal, and then instability at that level on top of tightness in the spinal canal, which means there's less room for the cervical spinal cord, and there isn't evidence on MRI that the spinal cord is being damaged, then you would do two things at once. In most of those patients, you would tighten down those ligaments to reduce the instability, because that can be irritating the cord. You would also do a platelet lysate or PRP epidural around that cord to try to promote some repair there. So that's generally the way that would be done. Stephen, if is posterior PRP able to help occipital neuralgia symptoms? How about central sensitization? Posterior PRP or platelet lysate delivered under ultrasound guidance around the occipital nerves is a good way to treat occipital neuralgia. Central sensitization depends on what's causing the central sensitization, but in general, in most sensitized patients, as we go forward with treatment, if we get rid of the cause, so many of our patients, the cause is craniocervical instability, the central sensitization component calms down. So I'll give you a great example from this week, right? I just treated a young girl, 18, 19, something like that. The first time I saw her, I couldn't touch her neck. That's classic definition of central sensitization. She's now, after 3 PICLs, she's now at a place where I did a full exam on her as I would anyone else in the clinic, meaning she's not in that centrally sensitized category at all right now. So that's a good example, right? We were treating CCI. CCI was the cause of that central sensitization, and it has calmed down as we've treated it. E. Smith, if muscles are shut down due to a flare-up, are you at higher risk of injury? Should you use a collar? The collar would be protective of injury, assuming it's the right kind of collar. But anytime muscles are shut down, you should be careful, because that is when people tend to get injured. So for example, in the low back literature, we know that factory workers that work in a bent forward or flexed position all day, their multifidus stabilizers tend to go offline, and they are more likely to get injured at the end of the day when those stabilizers are more offline. So you do want to be careful with that. Dr. Centeno is the best. My situation is severe, and I know I require a revision fusion. Listening is making me sad. Dr. Centeno can certainly be trusted. Well, thank you, Amy, for saying that. Let's see, Sunflower. Hello again. Have you seen any decrease in syrinx size with patients without Chiari that have gone through EPICL? Not usually, no. So if someone has a syrinx and there isn't any Chiari, then the syrinx may just be part and parcel of what they were born with. Now, there's one thing to say that someone has a syrinx, and let's define what that is for people who are listening here. A syrinx is when the middle of the spinal cord, which has a little tube going through it where cerebral spinal fluid flows, that middle of the spinal cord gets bigger, and you can see that on MRI. It looks like kind of like a large white stripe in the middle of the spinal cord. It's frequently either caused by a backup of cerebral spinal fluid from something like a more severe Chiari malformation, or it can just be there as part of someone was born that way. A third option is that it can be there due to trauma, where something happened and that caused the syrinx to form. But so we wouldn't usually see a decrease in size of a syrinx through an EPICL procedure, because it probably doesn't have anything to do with the craniocervical instability. Casey, have you seen patients with scattered instability at junctional segments, meaning OA, cervical thoracic, thoracolumbar, lumbosacral joint? Sure, that's common, yeah, especially in hypermobile or EDS patients. E. Smith, well, ligament that was injected with stem cells need to be protected from movement for weeks after. Not necessarily movement. You may want to watch that Thread the Needle video series that I have about rehab, because that's kind of what you want to do. Everything that heals in your body is pretty good at healing on the fly. And what that means is that your body will give you signs and signals that you should be doing less to allow more healing to occur, or you should be doing more to allow some loading of that part, because the first part is laying down tissue. So that means in that first 1 to 2 weeks, you probably in general want to do less unless you're very high functioning. And then after that, you start to get into that period of healing that really requires some loading to tell the body how that particular part needs to heal. So I would watch the Thread the Needle video series that I have. Cody, is it normal to have very limited range of motion a few days after a PICL? That is totally normal. Thank you, Natasha. Love all the hearts. Tamissa, if we go through you and have to travel from maybe North Carolina, can imaging and treatment be in one trip? Depends on what kind of imaging you want, but yes, all the imaging you would need is here. Now, if you don't have any movement-based imaging, you wouldn't be put on my schedule, because my schedule, because I'm only in the clinic now 2 days a week, is focused only on EPICL. So you have to be determined to be an EPICL candidate to get onto my schedule. Now, you could certainly get on Dr. Schultz's schedule, Dr. Pitts, Dr. Merkel, other doctors in my clinic, because then they would do the imaging out here and they would make the decision, do we need to do plan A or plan B? So yes, that can be done that way very easily. The DMX would be done at the clinic. If you needed something like an upright MRI with flexion extension, then that would be elsewhere, but still here in Colorado. Brooke, if I look up or down, it sends me into a month-long flare. was even hospitalized twice. I'm afraid to do the DMX. Can I still get a PICL based on instability shown in flexion extension MRI? You can, yes. So as long as the flexion extension MRI shows craniocervical instability that would warrant an EPICL and that meets the metrics that we use, then yes, you wouldn't need to get a DMX. Okay, guys, it's 11 o'clock. So I'm going to start winding this up over the next 5 minutes. I'm going to try to see if I can take some patients that haven't gotten anything in yet and have some interesting questions here. Shelby sounds like injured, had an upper cervical injury from a head thrust test in August. Neurosurgeon says that that you need a fusion, just qualified for PICL. So Shelby, I would need to know a lot more to answer that particular question. Almost everyone we see for PICL is a fusion candidate, but there may be other things going on here that are more subtle. So if I'm the one you did the telemedicine with, then you'd want to reach back out to me because you'll have the email that goes to my desk. If it's somebody else, reach out to that doctor. Concept of one pass at healing by the body of ligaments. Most patients are told to take ibuprofen to leave and ice the injury to reduce inflammation. Yeah, Cynthia, this is a great point. It is absolutely crazy based on the data that we have right now that we tell patients in acute injuries to take non-steroidal anti-inflammatory drugs like ibuprofen and Aleve when we have research showing that those drugs increase the prevalence of chronic pain and likely inhibit healing. Having said that, as you know, in this country, in particular, the pharma industrial complex is huge, and so I think you're right. Based on the peer-reviewed literature that we have to date, it's probably a bad idea to take those things in acute injuries. But you're right. Most doctors still recommend what's called RICE, rest, ice, compression, elevation, and then you throw non-steroidals into that whole thing. Let's see here. Trying to get some interesting ones here I haven't seen. What days of the week is DMX available at CSC and how much does it cost? Cost is $9.95. What days of the week is it available? Monday through Friday. Now, a lot of that's going to depend on the schedule of the rad techs. So you'll have to ask the clinic about what days are actually available that particular week. Let's see. Elias, are you doing only C0 through C7 injections still or just PICLs? For me, my particular 2-day a week in the clinic practice currently is only focused on EPICL. Now with that, that includes lots of other injections as well. C0 through C7 could be injected, nerves, etc. But I don't do any non-PICL patients at this point. And that's because about 6 months ago, I went from 3 days a week in the clinic to 2 days a week in the clinic. And there was no way to see the number of patients I needed to see who needed PICL in a timely fashion without only focusing on EPICL. USTAR, thank you for this. Educational. My rural area providers are confused. This is comforting to see someone understanding this. Thankful for you. Thank you, OnStar. Casey, when you first used platelet lysate, what was your initial procedure to obtain platelet lysate? The initial procedure was just an overnight freeze and then a thaw. As time went on, we figured out that you could markedly increase the growth factor levels by making it in different ways. So we ended up doing that. Let's see, I think that's it. Thank you, Dr. C. Julie, thank you, Julie. Live next Sunday at the same time. Yep, same bat time, same bat channel. Okay, guys, well, thank you so much. Try to give us a like, share, and on the way out, because that's how the algorithm determines whether or not it serves up this information to other CCI patients. If you want to pay it forward in the CCI community, that's how you do that. I will be here next weekend with more interesting stuff to talk about and more questions to answer. So again, thank you for all the great questions today. You know, in my experience, patients watching things like that, or sorry, patients watching things like this, when they're seeing other questions get answered that other people have, many people say, aha, that's me. Or, you know what, I always wanted to ask that, but I didn't. So thanks for participating. Thanks for taking the time today. Same bat time, same bat channel for next week. We'll go from there. Thank you.